Glass from Atlanta, Georgia. I'm an endodontist. I've been in private practice for about 15 years now, since 1997. Tonight we're going to be discussing how to achieve predictable success with endodontics, utilizing some new nickel titanium files that have been on the market about 2 years now. First, I'd like to go over this case here, which is one that I did myself around 2005. The case returned to my office, or the patient did, probably about 6 months ago. And what I'd like to do is discuss why we think maybe the case failed, even though we've obturated the mesial canals to length. And restorative considerations aside, it looks like maybe the mesial crown margin might have a slight overhang. Perhaps there's a void between the build-up composite and the gutta percha, but let's just put that aside and concentrate just on the root canal. When I looked back in my chart, I noticed that this was a necrotic tooth without a lesion, without a periapical lesion, and I did the treatment in one visit. And I'm going to present evidence throughout the lecture that may show that this is not the best course of action when treating necrotic teeth. The second thing that I did is I prepared the apical working widths, or the apical sizing, to a size 30 in both canals, and I'm going to present some evidence that shows maybe I should have taken it even larger. The third thing I want to discuss during the lecture is some ultrasonic irrigation, and I did not use that in this case because at the time the concept of continuous ultrasonic irrigation was not on the market. We didn't have any device on the market to accomplish that. So these three things are what are my best guesses as to why the root canal has failed here. And so we'll move on to the next slide and show some cases that have been done in our office. And I just want to point out that you're not going to be able to use rotary instrumentation in every case that comes into your office. Anytime we have some of these right angle bends on the left tooth here, the left molar, and certainly this one that's going off into either a buccal or lingual direction, we don't want to be putting rotary files into these teeth. And quite honestly, once you gain a glide path in these teeth, you have pretty much opened it up to where you want your sizing to be anyway in this type of curvature. So even though there are some advertisements out there showing rotary files going around these type curves, I would caution you to stick with hand instrumentation in these types of cases. Again, on this distal root of this lower molar that I just did maybe 3 weeks ago, this person's actually a dentist here in Atlanta. By the time that I enlarged the canal up here on the distal to gain my glide path, I had pretty much enlarged it enough to obturate. So I had to take this up with hand nickel titanium O2 taper files to maintain the curvature here on the distal. And I would not just take it up to a number 10 file and then start putting rotaries in, or you're going to block it or ledge it at this point right here. This next case here is showing a case that was done maybe a year ago in my office, and basically this is a good representation of the type shapes that I try to achieve when using the HiFlex controlled memory files. This one was also interesting because we had a Urkel lesion with no probing depths. There were no probing depths here. And as it turned out, we had a lateral canal in this tooth, and it did heal up, as evidenced here by the 10-month recall. Here we have some retreatment cases, and these basically, I'm put these in here just to show you, to try to gain your trust and that and get you listening to me. This really doesn't have anything to do with rotary, but this shows how inadequate endodontics, certainly here on the palatal root and here on the mesiobuccal root, you can actually go in and retreat these cases. You don't have to extract them and think about doing implants. If somebody spends enough time, you can actually get some good results in some teeth that have been incompletely obturated with their previous treatments. Now, I'm going to show a retreatment here that we performed, and I think everybody would agree that on the mesial canals here, these are just different angles, that, again, it's some incomplete endodontics. This picture, I always throw in a picture after I have removed gutta percha just to make sure I've gotten the canals clean. And this is in the interim where I'm waiting about a month with calcium hydroxide placed in the tooth to allow for the patient's symptoms to subside. Perhaps they had percussion sensitivity, or there may have been a draining sinus tract, something along those lines. I like to stay away from antibiotics unless we have some type of spreading infection. If we have a infraorbital swelling or a submandibular swelling, a buccal space swelling, that's when antibiotics are indicated. We don't want to use antibiotics for percussion sensitivity, for a sinus tract, and certainly not on vital teeth. Antibiotics in those situations will just cover up our symptoms, and we really don't know if we have eliminated the intracanal bacteria. So the problem with this calcium hydroxide, of course, is that it's not radiopaque. So this is one of my older cases, and since then I have started using radiopaque calcium hydroxide so that I can tell that I've placed it to length, and you'll see a case like that in just a few minutes here. So this is the completed post-op films of the same case, and I just want to show you how on a retreatment we do need to start thinking about getting some larger apical sizing. And I did accomplish this with nickel titanium files. I actually didn't use rotary instruments here. I used hand nickel titanium instruments, and this is on the mesial is probably prepared to a size 50, and the distal looks like it's a 60 or a 70. And I've thrown in the pre-op and post-op so you can see the difference here, and I hope all of you are striving to achieve the endodontics here on the right. And I've thrown in a 6-month recall. We do not have complete healing, but after 6 months, this is not a bad result. I lost track of the patient after that, so I can't show you complete healing. Let's go on to another endodontic case that showed up in the office. Again, everybody would agree this is inadequate endodontics. We know why this tooth failed. No questions. Right here, this is my post-op. I'm just going to skip over the file films and such. And again, just take a look at the apical sizing and look at how these canals, when you take an off-angle view, look at how wide some of these canals are. This is more straight on here, and this is more of an off-angle view from, looks like she took it from, my assistant took it from the mesial here. And you can see how wide this is actually in the buccolingual direction. So here again we have our pre-op and our post-op. It looks a little wider because this is an angled film. And here we have our 6-month recalls. And I always throw in the pre and the 6-month for you. And again, we have a little bit of a lucency here, but this is only after 6 months. So still, I think we're doing pretty good service for the patient by getting the patient to someone who can perform proper endodontics, and we don't have to look at extracting the tooth and putting an implant into place here. This root canal, again, another retreatment. This one here looks like it's pretty close to the working length, proper working length, but again, in the mesial distal direction on the film, we have really not adequately enlarged the apical extent of the root canal. This looks like maybe it's a number 20, and I would like to get up to at least a 40 in these types of situations. Over here, we do have the calcium hydroxide, radiopaque calcium hydroxide in the tooth to working length. And that's the thing you need to remember when doing your necrotic teeth, is that you need to make sure the calcium hydroxide is placed to working length. You just can't squirt it up here at the coronal parts of the canal. You have to place it the whole way down to the end of the tooth. So here is the post-op. One thing I always do after my cases is I place a barrier of flowable composite above the gutta percha, then my cotton pellets, and then the temporary restoration up top. And at that point, it goes back to the restorative dentist to get the permanent restoration or new crown, whatever they're going to have planned here. So I believe in this case, here we have our pre-op and our post-op, and it looks like just in the short time of maybe a month, we have a little bit of healing here between here and here. Keep in mind, this is just a month difference in these two films here. And next, I've got the 6-month recall, and I'll throw the pre-op and the 6-month recall up here. So I think, again, we've done the patient a good service. We've kept the platform here for the crown. We don't have any large embrasures that we would get with implant therapy in this situation. So I think this has worked out pretty well for this patient here. This is something that I was talking about a second ago. Again, this is the flowable composite barrier on top of the gutta percha after the root canal has been obturated. The flowable composite that I use is Synergy, and the reason that I like the Synergy is that we don't have to worry about slumping inside the tooth, and I'm not having any issues with bubbles. So there may be some others on the market. I'm just aware of Synergy that works well, and I believe Coltine Weldent is the maker of the Synergy. Also, in this case, I did use the HyFlex files, and this is another example of the type of shapes that you can get with the HyFlex instruments. Now, this is self-explanatory, but I'm just putting it in here to show you the benefits of using magnification, in this case, a microscope. And this would have been 6.5 times magnification, and basically, after I completed these 3 treatments here, I asked my assistant, and she placed cavit, and you can see the barrier or the demarcation between the cavit and the gutta percha. And the reason we did this is because the referring dentist does not like us to put flowable composite in his teeth or in his patient's teeth. And so if we look over here to the right, unfortunately, this is what happened after the restorative dentist went back in and without magnification. And so we've got an offline here. We've got voids, bubbles up here and stuff. So I'd encourage each of you, if you can work under magnification, you're going to find that you're going to enjoy dentistry much better, and you're going to have a lot less stress in your office. There is a learning curve with the microscopes, but after about 6 months, you'll feel fairly comfortable using them. Here, basically on the right here, I just want to show that somebody got ahead of themselves and with an immediate placement of this implant down the distal root socket here. Ideally, we should have waited for the healing to occur and then split the difference between the mesial and distal socket here. So as we have it here, we have the porcelain overhang, large embrasure, and decay has occurred here on this innocent premolar. Over here on the left, this does look like a proper placement. Again, with the large embrasures, we see a fair amount of this decay on the adjacent virgin teeth. So this, again, is something that I like to throw out for you to consider about actually saving the natural tooth, so we can, in fact, save these platforms so we don't have to be dealing with these large embrasures. Next, I'd like to talk about some canal morphology. And if y'all would just all look at the screen here, this is very important and probably the basic point of the whole lecture. This article came out in a dental journal, the Quad OE, in 2000. It's by Wu et al. And I want you to look at this number right here. This number is the average canal width in the mesiolingual canal of a mandibular molar in the buccal lingual direction, 1 millimeter from the apex. And we all try to instrument our cases to around 1/2 to 1 millimeter back from the radiographic apex. And in the buccal lingual direction, which is the view that we cannot see on our radiographs, we're seeing that the average diameter is 0.38 and the mesiobuccal canal is 0.4 millimeters. And that would correspond right here to a number 40 file. So if we are thinking about preparing our canals with some of the file systems on the market that stop at a number 21 or a number 25 file, we are not going to be adequately removing infected dentin in our necrotic teeth in the buccal lingual direction. In the mesial distal direction, the direction we do see on the radiographs, as you can tell, the canal is much smaller in that dimension. It's more ovoid in the buccal lingual direction. So really think about these numbers and take a look down here in the distal canal of the mandibular molar. It's even worse, at larger than a number 45 file. This article is widely quoted among endodontists and is one of the most useful articles that we have to help us determine our final file sizes during our endodontic treatments. So once again, we're looking at about a size 40 file to adequately clean some of our smaller canals, the mesial canals in the lower molars. This chart right here, and I think y'all will be able to get access to this after the webinar, but this chart shows the recommended file sizes that you need to be instrumenting to for pretty much every tooth in the mouth here. I did not make the chart myself, but if I had made it, I would have made it exactly like this. And if you notice at these numbers, the smallest number on the chart is a 35. There's no recommended instrumentation sizes lower than a number 35. Here we do have a mandibular premolar in the buccal lingual direction, and basically you can see how much wider or ovoid it is. If we flip this 90 degrees, it's going to look much smaller. That's the view we get on our radiographs. Here apically, it is very small. Maybe we're talking about a 0.2 as the canal exits the tooth in the foramen area. But very quickly, 1 millimeter back, it starts to enlarge, 2 millimeter back, and it gets very large very quickly. And this area right here is the area where we're terminating some of our instrumentations. I think everybody that is practicing dentistry these days is aware of our MB2 canal in our upper molars. It is a source of continued frustration for some of you. I gotta tell you that it's going to be very difficult for you to locate these canals unless you are using increased magnification. The studies show that they are present in about 96% of the first molars. That number is going to be a little bit smaller in our upper second molars. Often it's hidden underneath dentin. Sometimes you need to go troughing to locate it. And notice it's not quite in a straight line between the mesiobuccal and palatal canal. It's going to be off just a little bit. So you want to kind of straighten out your access right here. We were all taught about somewhat of a triangular access, but you're going to have to drop straight down right here to be looking for some of these MB2 canals. We use ultrasonics to locate these under magnification. This is what they look like under magnification. Frequently you'll see a small developmental groove here, and usually the MB2 canal is located at the end of this developmental groove. So what I would do here is start my ultrasonic tip here and just trough in this direction, and usually you'll uncover a stick there with your Endodontic Explorer, and that's where you want to start searching. Same thing over here. This is going to be where your MB2 is. This just shows the progression of finding it and instrumenting it. And you do want to be instrumenting and obturating these because any bacteria left inside the tooth or any food source, any canal tissue is going to cause a failure at some point down the road. This is an ultrasonic unit currently on the market, which is made by Acteon, and there are at least 2 others on the market that I know of. Any ultrasonic unit these days will work quite well. This is a very nice tip right here. It's by Coltine. It's the USC 4S or 4E, depending on if you're using the Satellec or the other type system. The reason that I like this one ultrasonic tip here is that the end of the ultrasonic tip is flat. When you are troughing for these canals, it is useful to have a flat end versus a pointed end. An ultrasonic tip that comes to a point is going to gouge the tooth structure, and you're going to get lost very quickly when you're searching for these hidden canals. Now, there are some other ultrasonic tips on the market that have a flat end, but they do not have the diamonds running up the side. The reason I like this one is that you can use it in a lateral direction as well as troughing for your canals. So we can also be expanding our access a little bit while we're looking for the canal systems. And again, this one comes from Coltine and is the USC 4. Another problem that we encounter is an extra mesial canal, which is known as the mid-mesial canal. The mid-mesial canal does show up in 15% of lower molars. And in a moment, I'll show you a case with a mid-mesial canal. This, again, is found through troughing a developmental groove between the mesiobuccal mesiolingual canal system. Basically, take your ultrasonic and move across in this direction, and usually you'll find a stick right here. And for the most part, this one canal drops into one of the other main mesial canals. But again, you want to go ahead and instrument it because otherwise you're going to be leaving bacteria within the canal system. This is just that. This is going to be showing you a mid-mesial canal. Now, I don't know exactly why this root canal failed. We have a periapical lesion, and certainly it could have failed because of the incomplete obturation here in both canals, or it may have been because of the missed canal, but likely it was a combination of both of them. So let's go through some of the file films. This is going to be during the retreatment, and this is a mesiobuccal canal. This is the mesiolingual canal, and this next film shows the mid-mesial canal. And you can see here it comes down here and then it bends back in this direction. So that's our third canal. I couldn't get one with all 3 files in there because the handles were too wide for me to show you one that way. This is our post-operative, and here we can see the 3 canals. And like I said, generally this mid-mesial will fall back into one or the other canal systems. Here it looks like it falls back into the mesiobuccal. The mesiobuccal is always going to be your most curved canal. Again, this is taken at an angle. That's why we're able to see this. This one obviously is not taken at an angle. I would encourage you when you do your post-operative endodontic films to start taking them at an angle, and you'll start seeing some interesting anatomy, and it'll make your day a lot more interesting. You'll enjoy your work a lot more. On this particular tooth, I picked up a second distal canal that I didn't even know was there. I just picked it up with warm vertical condensation and the ultrasonics, and it happened to appear there, but I never ran a file down this right here. Okay, so here is our pre-op, our post-op. Again, the pre-op and the post-op, and these are much larger than a size 25 or 30. Okay, I'm sure this was prepared to a minimum of a size 40, and I'm thinking it's probably a number 50 nickel titanium hand file. Now, I would not take a virgin tooth up to a number 50 in most cases, but when you are doing retreatments, you do have to remove the gutta percha, and so you are going to have to think about getting some larger sizes down here, even larger than the size 40. And if we look at the next view, I think we'll see that we have some healing here after 6 months, and I put the pre-op for you here, and we definitely have bone fill here, if not complete fill. The problem is I've got an off-angle view, so we might have a little bit of a lucency still here, but I have no doubt that this will eventually resolve. This is another view of the recall. Definitely have healing. We've got a PDL forming at least up to right about here. Let's talk about a little microbiology. About 6 weeks ago, for those of you that are international, I did some lectures in Southeast Asia, and I found in some of the countries that the rubber dam is not being utilized. And I just want to say that if you're not going to be using the rubber dam, you're not going to be able to keep your canal system sterile, maintain sterility, and your endodontic treatments are not going to be as successful as you would like. And then, quite honestly, most of them are going to fail. I know some of you, especially overseas, are hesitant to use the rubber dam because you're not quite certain that you can place it properly. But I would encourage you to have one of your, maybe your front desk, or if you have an assistant, to practice on them some. And really, placing a rubber dam is not difficult if you just spend a little bit of time to learn how to use it properly. This is a clamp system on the market made by Colteen, and the clamps are actually a matte or brushed finish. They're not shiny, so that when you place the clamp within the hole and take it to the tooth, the rubber dam does not slide off of these clamps, and it makes you look a lot more competent to your patients. These clamps right here, you can generally do most molar teeth with these two clamps, and you want to make sure that the wide part of the clamp here is usually towards the buccal, but not always. If you do put the clamp on a molar tooth and the bow of the clamp tilts forward over your access, then simply pull out the opposite clamp, and usually that'll seat down fine. The other two clamps that you're going to need for doing endodontics, this is going to be your premolar clamp, and this is going to be your anterior clamp. And literally, for most of you, especially general dentists, you can probably get by with 4 clamps, 4 different types of clamps in your office. Always have a spare of each type of clamp, because eventually your clamps will wear out and they'll break in the bow right here. So you always want to have a spare on hand in case that happens. This right here is improper rubber dam placement. We have not covered the maxillary teeth, and the saliva is absolutely going to get onto your gloves as you try to work in this environment, and you'll contaminate your working field. This is a correct rubber dam placement. Just make sure you keep it off the patient's nose, but we're covering the whole oral cavity here. Now, this right here, some of you, when you place your rubber dams, you may still have some salivary leakage, and what I would recommend in that case is if you get your pens and paper ready, if you get some Orasil caulking that is from Ultradent. That's what this is here. And you can squirt this caulking material around the cervical part of the tooth, and you can even go underneath the clamp wings. And if you floss between your contact right here, then you're probably not going to have any salivary leakage the whole time. And when you look at this right here, who would want to work on a tooth without a rubber dam when you can have this type of isolation? You're just making it hard on yourself if you ignore rubber dams. Now we want to take it one step further, and this right here is just some iodine solution or betadine solution, and we want to sterilize the working field here before we access the tooth, because if we're going into a vital tooth, a non-infected situation, we don't want to carry the saliva into that as we're doing the root canal. We don't want to take a canal system that was not infected and introduce bacteria in it. So this is what we want to do. We want to clean off our working area before we access these teeth. If we have decay in the tooth, we want to remove the decay, just like we do in operative, and then we want to place our iodine solution, get a different burr or diamond, whatever you're using to access the tooth, a new sterile diamond before entering the pulp chamber. That way we are not introducing the bacteria into our canal system. And speaking of bacteria, most of the studies up until around 2000 of testing or antibacterial medicaments or irrigating solutions were done on planktonic bacteria, which means free-floating bacteria. Now we have identified within the canal system something we call biofilm. And biofilm is just an aggregate or a collection of bacteria which is attached to the canal walls. And in order to remove biofilm, we either need to mechanically remove it with our files, or we need to ultrasonically remove it with our irrigating solutions. This right here shows some of the biofilm collecting on the intracanal dentin. Again, this biofilm is going to be along the whole surface of the canal. It doesn't just collect apically down here. And this is going to be one of those canal systems that you're not going to want to take a file that's this large, if we even have them, and plane all these walls. So we're going to have to look at using some ultrasonics to clean the upper reaches of this canal system out, as well as adequately enlarging the apical extent of the canal system. Again, mechanical debridement is critical for removal of the biofilm. Let's talk a little bit about the irrigation. This study done back in 2003, which was published in the International Endodontic Journal, tells us that when we use our hand in rotary instrumentation, up to 49% of the canal walls remain untouched by our instruments. So that means about half of this biofilm is remaining on the canal walls. We also know when irrigating, according to this study, also in the International Endodontic Journal in 2009, that when we use our passive irrigation needles, the irrigants only reach 1 millimeter beyond the tip of the needle. So this is going to tell us in a moment that we need to enlarge the canal system or the apical extent of the canals sufficiently to get our needles within 1 millimeter of our working length. At present, the smallest gauge needle on the market is this purple, and it's a 30 gauge. If you take a gutta-percha gauge and you put this needle through a gutta-percha gauge or a measurement tool, you have to have a minimum size of a number 40 file to get this smallest gauge needle to working length. For the 27 gauge needle, which is the yellow one in this picture, you need to have a minimum apical size of 50. So in a moment I'm going to show you why it's important that we are actually exchanging our irrigating solutions while we are performing our endodontics. So if we only prepare our apical extent or our working widths, our final apical sizing, if we only prepare it to a 25, we will never get our passive irrigation needles anywhere close to working length to properly exchange our fluids, our hypochlorite, our EDTA. And why do we want to exchange our irrigating solutions? Well, these days we don't just use sodium hypochlorite and EDTA. We also want to be using 2% chlorhexidine as a final rinse in all of our necrotic cases. If we mix sodium hypochlorite and 2% chlorhexidine, we will get a precipitate called perchloroaniline. And you do not want this precipitate in the tooth. It is very difficult to remove. It's much like road tar or gum. It's just very difficult to remove, and it's also been shown to be carcinogenic. So what we use is an intermediate rinse with EDTA after the sodium hypochlorite, which will inactivate the sodium hypochlorite, and then we can use our final irrigation with the 2% chlorhexidine. So sodium hypochlorite is antimicrobial, and it does dissolve the organic material inside the tooth. We do need to be using sodium hypochlorite initially when performing our root canals. Now, something that many people have been confused about in the past is some people think that the concentration of the sodium hypochlorite is more important, higher concentration is more beneficial to kill the bacteria within the tooth. But what we now know through studies is that it's volume and frequency of the irrigation that is more important than the concentration. So you can actually dilute your 6% sodium hypochlorite. You can dilute it by a factor of 10, and it will still give you the same antibacterial effects. I dilute it by half in my own practice. Here we have the EDTA, which is actually removing the smear layer. That's our second rinsing solution. And the one reason that you want to use the chlorhexidine as the final solution is this word here, substantivity. And that means that the 2% chlorhexidine keeps working for you up to 60 days after you obturate your teeth. It is still exerting antimicrobial effects within the canal system, 2% chlorhexidine. Now, it does not dissolve tissue, so we can't use it by itself, and it's no more effective with its antibacterial efficacy than sodium hypochlorite, but it does last longer. This is showing some of the canal systems. This has been known since 1925. This is some sectioned teeth, and we see some of the difficulties that we have when doing endodontics with some of these canal systems. We're going to need to be using some ultrasonics to get rid of the debris in these isthmuses here and here. This is showing some of the tissue left in the isthmuses. Again, this is going to be an isthmus here on a root end. We're obviously never going to get a file down this, so we're going to have to rely on some ultrasonics and some type of obturation technique that will allow us to place gutta percha within these areas. This study right here in the Journal of Endodontics from 2005 shows canal cleanliness following ultrasonic irrigation. And if you look at 2 millimeters back from the apex, roughly no ultrasonics, here the blue line, and ultrasonics are about equal. But if we look at isthmus cleanliness, Going back to 3 millimeters, there's a humongous difference between no ultrasonics and ultrasonics. So we want to start thinking about using some ultrasonics during our endodontic treatments. Again, this shows before ultrasonics with isthmus tissue and afterwards. Now, how does this work clinically? Basically, if we do use our ultrasonics, we can achieve an 80% negative culture after using 1 minute of hand and rotary instrumentation along with ultrasonic irrigation following hand and rotary instrumentation. A negative culture is the threshold at which we can expect to achieve the same success in a necrotic tooth as a vital tooth, which is very important. This is one of the ultrasonic irrigators that is going to be coming on the market. It is a Canal Pro ultrasonic irrigator, and it's going to be marketed by Colteam. And the idea for this is, as you are using the ultrasonic on your current ultrasonic device, this tip right here will be vibrating. There will be a syringe of hypochlorite attached to this tubing, and your assistant will be irrigating through this tubing and out the end of this syringe right here as you're ultrasonicking. It is called continuous ultrasonic irrigation, and it's very different from passive ultrasonic irrigation, which is when you place hypochlorite in a canal and you place an ultrasonic irrigant in there, but you're using the same solution for the whole time you're irrigating. This continuously replenishes the solution. This right here has been shown, this technique, to be more efficient at removing the isthmus debris and tissue. Again, it's going to be marketed by Colteam, and I expect it overseas. It is already on the market in Asia, I know, and in the U.S. it will be coming up here within the next few months. When you use your ultrasonic system, you'll start noticing these dark lines between some of your canal systems, which is just an isthmus that is now cleaned out. This is not a fracture of the tooth. This is normal anatomy that would have been present when this patient was much younger. Here we show some isthmuses and how important it is to get the gutta percha into these areas with certain obturating techniques. Most of the treatments that I perform now do not show single dots of gutta percha. I have some connections of gutta percha through these isthmus tissues. Here we have it right here, one of the isthmuses. In the microscope, if you get straight down these, you can literally see, if the canals come back together, you can see where you're putting a file in one canal, and you can see it coming in over here, down towards the end of the tooth. Now let's talk a little bit about success rate in endodontics. And this is what we want to try to achieve, is the 94% success rate. But we have to get a negative culture in order to do that. So I'm going to tell you how to predictably get a negative culture. So in this study that we're looking at here, this is the criteria right here, but the main thing to look at is that they used a minimum apical size of 40. Okay? They did every tooth in one visit, and when they did every tooth in one visit, they found out that they had a certain number of positive cultures and a certain number of negative cultures. And of the positive cultures, meaning bacteria was still present in the canal, they had a much lower success rate than they did when they have a negative culture. The problem is, when we are in our office, we don't know if we have a positive or negative culture. These people here, they took cultures right before they obturated the teeth, but we don't do that in practice. So we have to go with a technique that allows us to predictably obtain a negative culture. So here we did some statistics here. We found according to the study, if we one-step every necrotic tooth with a lesion, we're only going to have an 84% success rate. But we want to do better. So, like I said before, we don't know if we have a positive or negative culture, but our research shows if we follow certain protocols, we can get a consistent negative culture. And I've mentioned this before. I'll just leave it up for a second. So this is a set of studies done back in the late 90s, early 2000s at University of North Carolina. This first study shows that if we instrument our canals to a 25 at the apex, and they were using an 0.4 taper in the study, if we use saline as an irrigant, which is not antibacterial, we will only get a 20% negative culture. No one should be using saline, but they were using this somewhat as a control as their first part of the study. If we still use saline, which is not antibacterial, but we increase the size, apical sizing to a 35, we can increase our negative culture from 20% to 40%. Okay? So just by increasing the apical size, we've doubled our negative cultures. Now, if we use some hypochlorite, and look here, it's not full strength, but if we use some hypochlorite, amazingly, at size 25, you have the same antibacterial efficacy with sodium hypochlorite as you do with saline. Once again, if you're only going to instrument to a size 25, 0.4 taper, sodium hypochlorite is going to be no better than saline at eliminating the intracanal bacteria. However, if you increase your apical sizing to a 35, you're going to get a 60% negative culture using sodium hypochlorite. But this by itself is still not good enough to get us to the same success rate with a vital tooth as with a necrotic tooth. So what else can we do? Well, first off, some people advocate soaking the tooth in hypochlorite for 30 minutes. And at size 25, using full strength hypochlorite, 17% EDTA, there's no increase in antibacterial efficacy by leaving the tooth soaking for 30 minutes. All you're doing is wasting the patient's time. So once again, it's volume, not concentration, of the sodium hypochlorite that decreases the bacterial count. You have to continue to replenish your irrigating solution throughout the treatment. The increased hypochlorite concentration increases tissue dissolution only. Okay, moving along. If we add 1 week to 1 month of calcium hydroxide therapy, and remember the calcium hydroxide must be placed the entire length of the canal, we'll get a 90% negative culture. When you get a 90% negative culture and you run the numbers, that will give you a 94% success rate, which is the same success rate that you can achieve in a vital tooth. And this is how you achieve predictable success with endodontics. If you try to one-step this next, let's talk about this first. This is the best way I know how to place calcium hydroxide to length in your teeth. This is marketed by Ultradent, and this is called UltraCal calcium hydroxide. This is a 29 gauge needle, and once again, it's slightly larger than the 30 gauge. You're going to have to enlarge it to a size 35 or 40 to place this to length to get your calcium hydroxide to look like it did in that one retreatment picture I showed you. It's marketed by Ultradent. If you want to one-step, the study shows that you can achieve an 89% negative culture if you increase your apical sizes to 60. Now, we all know that a size 60 is not going to be reasonable in some of our smaller roots and curved canals. But if you want to try this in your central incisors, some of your canines, your maxillary central incisors, then according to this study, you should have the same success rate in a vital tooth and a necrotic tooth if you do increase it to size 60. In the smaller teeth, we don't want to do this. We may set the teeth up for fracture. The gist of this one study back in 1996 shows that the greatest incidence of healing or emerging disease is at 1 year. That's why we take our 1-year recalls. This is a opinion piece back in the Journal of Endodontics in 2005. The clinical philosophy that apical preparation sizes should be kept as small as possible rather than as large as required, disregards existing scientific literature, and appears to be based primarily upon clinical opinion. Again, this is talking about the recommendations in necrotic teeth: rubber dam, minimum size 35, larger in single canals. Continuous ultrasonic irrigation with that Canal Pro I was talking about. Intracanal calcium hydroxide from 1 week to 1 month. You basically want to wait until your symptoms resolve. You need to be placing your temporary restorations if you allow your assistants, unless it's my assistant. I'm laughing. You need to place them yourself because frequently your assistants are not going to put the temporary where you need it. You're going to get leakage in our appointment. We use our 2% chlorhexidine at the second visit before obturation, anywhere from 2 to 5 minutes. Obturation is delayed on necrotic teeth until the tooth is asymptomatic. No antibiotics unless we have a spreading infection, submandibular, infraorbital. Let's talk a little bit about some files. This is a hand file right here, and it is a nickel titanium hand file marketed by Coltine called a HyFlex X file. This is what I use to obtain some of those larger apical sizes. The reason I like the X file is because it does cut in both directions, clockwise or counterclockwise. These are the new HyFlex files that are on the market, and the benefit of these files is that you can pre-bend them before placing them in the canal like it's showing here. So this helps a lot when you have a patient who has a limited opening. In every other file on the market, you cannot pre-bend them to place them within the tooth. But also, I can bend this, but I can also straighten it again, or I could bend it in the opposite direction. These files don't care what position they're put in. They will bend in any position you want them to go in. And so this is very beneficial, like I said, gaining access in people who have limited openings. And it's also beneficial, obviously, in your curved canals because we don't have to worry about any type of apical transportation in these situations, which is shown by these cartoons here. The HyFlex, once again, when it goes around a curvature, it does not try to straighten out. It doesn't care what position that it is placed. It does very well in the cyclic fatigue test as shown here. Well, the recommendation is that you use it for 3 teeth, and that is whether or not they have 1 canal or 4 canals. 3 teeth and throw them away. In my office, I use them in 2 teeth, and I have not had any separations. I've never had a separation, and I've been using them for a year. But I do throw them away after 2 teeth. But they can be used up to 3 according to the manufacturer. This is the design. Very easy to tell. It has the color-coded band as well as the taper. Comes in 29 different sizes. Now, pay attention here because you may not have seen this before. If anybody has experience with the Pro files, the first nickel titanium files that came on the market, you'll remember that they unwound. And these files do the same thing at times, except that when these unwind, studies show that half the time when you put them through the autoclave again, they'll rewind and you can use them again. And in the classes that we teach, we just take a lighter and we hold the heat underneath not the flame underneath but we have the flame away from this, but the heat will rewind these on the spot, which is very interesting to see. So this one's okay to use. This one's still okay to use as long as it rewinds. But if they do not rewind after heat treatment or autoclaving, then you need to discard them. And I would count an unwinding as one of your 3 uses also. Let me go back to this real quick. When the files that I have unwind with my technique, always unwind in this last flute right here. And this is very difficult to perceive unless you pull a second file out and hold them up together. I do not see this type of unwinding myself. And I'll show you my technique in a slide in just a moment. These are the different sizes that they market. You're not going to probably need every one of these sizes in your office. The technique that I find works best with these files is actually not the technique that comes in their instruction manual. I like to use a full length technique, meaning you take each file to working length. I like to start off getting a glide path to a 20 file, a 20K file, and then I like to use Gates Gliddens coronally, a number 2, 3, and 4 Gates Glidden coronally. Then I introduce the 0620 file, and this is the one that's going to work the most because it's removing the initial dentin in the middle third of the canal system. You need to be running these at 500 RPM. Set your torque value to 2.5. It is important to run them at the proper speed, and it's very beneficial to have a torque control on your handpiece as well as auto reverse. Go to 0620, 0625, again 2 length, 0630. Now when you get to 0630, you're going to find if you take a number 35 hand file, O2 taper K file, that it'll likely drop down to length right here. Now, according to those studies, that will be enough in most cases to eliminate the intracanal bacteria. If you want to get a larger size, at this point I recommend dropping down to their 04 tapers with your 35 and your 40. The canal systems I'm talking about here would be our curved canals. Obviously in our central incisors we're going to be going even larger than this. But this would be in our smaller mesiobuccal canals of our upper molars and our mesial canals of our lower molars. This is the technique I'm showing here. I don't recommend taking a 3506 down those smaller canals. You're going to have to drop down and taper, or either at this point start using some hand instrumentation. So basically we enlarge it here, 0630, and as an additional step, further enlarge the apical portion of the canal system. Now, a few other systems that are on the market. The first one that I'll introduce is the Wave 1, and according to this study that came out in June 2012 in the Journal of Endodontics, Wave 1 files are showing that they are producing more debris out the apex, apically extruded debris, compared with full sequence rotary systems, and that's the traditional rotaries that we have all used up to this point versus these reciprocating systems. Now the second study out on these Wave 1 files is talking about isthmus cleanliness. And there is an issue with this and these files. If we compare them to K3 files, which are marketed by Cybron, you're going to see that the isthmuses are not as clean as a couple of standard or traditional file systems. So this right here, the middle row right here, is showing the isthmus tissue according to this study, or debris that is packed in. This is really debris that's packed in when using the Wave 1 files. And these are some traditional file systems here and here. So once again, that study was in the Journal of Endodontics, August of 2012, and this view right here, this is pulled directly from that study, showing this row right here and the debris that is piling up in these isthmuses. Now let's look at a second thing about the Wave 1 files, and it's basically their tips that they're using. So we've got a 21 and a 25, and already we know, based on our study from Wu et al., that this is not going to completely plane all the canal walls in a buccolingual direction of most teeth. It's also not going to allow us to get our calcium hydroxide needle to length, and it's not going to allow us to get our irrigating needles to length. And unfortunately, the next file size up that they go to is from a 25 to a 40. And if you've ever held one of these 4008 files in your hand, we have zero flexibility in these. They're all single use as compared to 3 use for the HyFlex. I was just at the Greater New York Dental Meeting, held this file in my hand, and this file isn't very flexible itself. So basically, if you don't have a flexible file system, you are going to try to keep your tips smaller, and you are going to try to develop some type of technique that justifies keeping your apical sizes smaller. But as I've shown you with some research here, I don't think that this is the way we need to be looking at cleaning out our canals with these smaller apical sizings. Now let's talk about one other file system that probably many of you have used, which are the Pro Tapers. Now, according to this study in the International Endodontic Journal in 2012, if you do instrument long with a Pro Taper instrument, you are going to transport the major foramen, and that's going to make it difficult for you to properly obturate the canal system. Again, this is not my opinion. I'm giving you all research here. It's readily available if you Google it on the internet. This study here, also talking about Pro Taper and their F3 and F4 instruments, and F3 is a size 30 at the tip, and F4 is a size 40 at the tip. And the F4 size 40, remember, size 40 is what we want to be instrumenting most of our necrotic teeth to. And according to this study out in the Journal of Endodontics in June of 2010, after the use of F4 instruments, 22 roots presented apical root transportation in the buccolingual direction and 18 times in the mesial distal projections or direction. So 22 roots in one, 18 in another. So basically, the problem with this is the buccolingual direction. You are not noticing this on your radiographs. The buccolingual projection is not what we see. We only see the mesial distal. Most cases of this transportation are between 0.1 and 0.2 millimeters. So if these very stiff files are placed to length in these canals, you're going to leave some of the canal surface uninstrumented because these files are trying to straighten out. Now, according to the same study, their findings suggest that the Pro Taper F3 instruments should be used with care in curved canals. Now, these are the ones with the 30 tip. You should not go to the working length, and F4 instruments, that's the size 40, should be avoided when preparing the apical third of curved canals. So again, I throw in a picture of the new file system that is on the market here, the HyFlex files, and just show you that you're not going to encounter these type of issues. And this is actually a number 4006 taper file right here. And you can see the amount of curvature that you can attain in this. Now again, I don't advocate putting a 4006 down the smaller canals because right here it's going to get too wide and we're going to remove too much coronal dentin. So we're going to use the 2006, 25, and 3006, and then we're going to step down to an 04 taper or either use some hand files to further enlarge the apical extent. So in summary, what I've tried to teach y'all is that we need to obtain larger apical sizes to mechanically remove the biofilm in our necrotic teeth to allow for apical penetration of our sodium hypochlorite, or EDTA, and our chlorhexidine, and to predictably place our calcium hydroxide to full working length. So what I'm going to do now is look down at some of the questions that we've gotten, and I'll try to answer a few of them. And this one comes from Martin Zone, and he is asking, what method do we use to place calcium hydroxide to the apex? And I think I did cover that, and basically what we're using is the Ultradent UltraCal calcium hydroxide with their 29 gauge needles, and that is how I am getting it to length, but I'm also enlarging the canal system to a minimum size of number 40. Keep in mind, we don't need to really be placing calcium hydroxide in our vital teeth because we don't have any bacteria. So we can look at keeping the shaping smaller, maybe at a size 35 on our vital teeth. But in our necrotic teeth, we need to go a little bit larger. So let's see. The next question comes from Rita Phillip. What are the options for small, narrow canals when the canals are too small and narrow to allow beyond a 25 file? And that is a great question. And yes, there are going to be some anatomic limitations, but what I find in my practice is that those are very rare. But I am not advocating in a right angle bend or a very narrow route. I am not advocating taking it up to a number 40 file. But you may find that you need to use, or you may need to spend more time getting your calcium hydroxide to length. It's going to be very difficult. You need to take a film afterwards to make sure you get it to length. You're going to be doing a lot of stabbing at the calcium hydroxide with your hand files. You're going to be maybe trying to place it with some very, very fine paper points. But yes, we do not prepare our small or narrow canals larger than the tooth will allow, and certainly not around right angle bends. But that does not come up very often, but that's a great question. So the next one is from Rennie, and it says, does the calcium hydroxide interfere with the seal apex? And that is and I'm not sure if you're asking with the, if you're asking the seal at the apex, or if you're talking about the sealer on the market called Seal Apex. But I'm not aware of anything that the chlorhexidine, the 2% chlorhexidine, will interfere with other than the sodium hypochlorite. Okay, another question. This comes from Adele. In retreatment, let's see, in post-operative picture, there is resorption, and I can't read the rest of it, and that's going back to a different tooth, so we're going to leave that one alone. And let's look at this question here from Rennie, and it's, do you have any recommendations on getting the gutta percha out in a retreatment case? And yes, I do. You're going to need to use chloroform, and in that situation, you cannot run the chloroform through the tubing of that new irrigation system I was talking about. So what you're going to need to use is passive ultrasonic irrigation. So take your chloroform and put it in a syringe, and you're going to need to get one of the harder syringes that doesn't melt. Place that into the canal system and use your ultrasonics. And you can also use some paper points to drag some of that gutta percha out, but it does take a lot of time. It's very time consuming to get gutta percha out of retreatments, and that's why I was trying to show you the picture of when I had removed all the gutta percha, because you don't want to let the patient go after that first visit until you've removed all of the gutta percha. So we may have one more question here, and this is talking about Pulpatec in endo treatment, and I'm not familiar with that product, but that's not to say that it doesn't work. I found when I traveled overseas, there were many products that are not marketed here in the United States. And the last one is going to be from Wilfred, and it says, how do you clean lateral canals? And the lateral canals, and we're about to log off here, the lateral canals can only be cleaned with ultrasonics. So the continuous ultrasonic irrigation is going to push that hypochlorite into these lateral canals. Good night and thank you.